Now, the nutritional aspects needs to be considered on the different way. It could be undernutrition as well as overnutrition. Undernutrition are important aspects in management of patient on the any discipline, medically or surgical areas. Now, undernutrition is actually what I think about as a respiratory physician, as a general normal doctor. It is important where we need to provide the nutrition according to the demand. It depends on the age, sex, activities they carried out, and the development needs to be considered, and the various aspects of their need. Where the nutrients like protein, carbohydrate, lipid, as well as vitamin and trace elements are mandatory. So it needs to be provided nutrition according to the demand. Other way of undernutrition as a clinician, we face that providing the nutrition according to the needs, according to the demand, like in the illnesses, acute or chronic illnesses, where we have a higher demand of nutrition due to various aspects, like in hypercatabolic status, where the inflammatory response, or it may be due to the losses due to, for example, like in a surgical management, where it is important to think about the nutritional status of those patients. Now, I'll take as an example, like even acute events. For example, I'm a respiratory physician, where I say, but for example, if I get a patient with a multilobar pneumonia, needing ventilator support, when we treat the pneumonia with the ventilator support, with the respiratory failure, now we are treating the infection, pneumonias with the various antibiotics and all other supportive treatment. But if I forget about the nutritional state of the patient, I need to invariably to understand that nutritional deficiencies of the trace element, vitamin, and other important will cause hyperproteinemias, muscular weaknesses, diaphragmatic difficulties, weaknesses, where the muscle weaknesses, so that when the pneumonia is improved, I may not be able to be in the patient unless the patient has a normal muscle function, normal neurological status. Now they are more prone to get what is called the status where all the inflammatory response and the neurological status are down, then the management and weaning off will be difficult, and we will give you another problem, like in the secondary infection, respiratory failure due to the muscular weakness, we call critical illness neuropathy. This is some example. So likewise, acute versus chronic was important. Whenever there's a chronic diseases, medically or surgical one, unless we provide the adequate nutrition according to demand due to hypercatabolic status, that will be another major problem other than the original problem. Is very important. Any chronic illness, they are facing to the nutritional deficiencies, chronic anemias, vitamin deficiencies, various losses due to their primary problem, and hypercatabolism, increased demand. So they are more prone to develop the vitamin deficiencies, trace element deficiencies, and the protein and other deficiencies that will lead into the other consequences. So addressing the nutrition state or the management of chronic diseases is a mandatory requirement, and is optimistic and the optimal management of the patient, where it is important to provide the adequate nutritional with. For that, we need to have adequate knowledge. So we have dealing with the increased demand for the acute or chronic illnesses, as well as a demand associated with the development and the various activities that are carried out. Other problem what we face, what we see as clinicians, are the overnutrition, where it affects from the babies to the adult, elderly. When you have undernutrition, we have consequences equally, overnutrition as well as we have consequences, where the morbid obesity and the general obesity are associated with several medical, surgical, and mechanical problems. For example, my own field, respiratory medicine, the patients with overnutrition can be associated with the obesity and the obesity hyperventilation syndrome, sleep apneas, restrictive lung diseases, prone to malignancy, so on. So the overnutrition, the obesity can associate, one is the malignant predisposition, mechanical problem, arthritis, respiratory diseases, as well as metabolic problem, like as you're well aware that diabetic mellitus, hypertension, coronary artery disease, ischemia, etc. So it is important to address this undernutrition as well as overnutrition. Knowledge on these areas are mandatory as a general doctor to practice. Not only that, as a general public. their nutrition status, how they maintain nutrition, how they provide the nutrition according to demand is a mandatory requirement. Now, we jointly organized by our society, Cancer Society Medicine, and Sri Lanka Medical Nutrition Association, we thought to address these various issues and upgrade the knowledge of the various discipline of medicine, like a medical fraternity, as well as surgical, and as well as from the student to the clinician, to upgrade their knowledge about the nutrition. So we invited experts to talk on these different areas, ranging from the chronic illnesses to the obesity on the young and adults, as well as metabolic disorders like diabetes mellitus. So we are planning to give us the update knowledge on this different discipline, and to this knowledge will definitely going to helpful your management of your patient, thereby giving the optimal treatment, not only the medical and surgical, providing this other important aspect, finally, as a very good and expected final results. So here we have invited 4 speakers. We have the first speaker, Dr. Renuka Jayatissa. She is a consultant clinical nutritionist, and as well as she is the head of the Department of Nutrition, Medical Research Institute of Colombo, and she is the current president of Sri Lanka Medical Nutrition Association. Dr. Renuka Jayatissa is going to speak on the chronic diseases, concentrating on medical nutrition therapy in cancer, where it will be mimicking the all other chronic diseases. And so you can listen to our speakers, and whatever queries you have, you can send us in the chat box, and where we will be answering all the questions at the end of the webinar, and we will be directed to your question to the respective speakers. Now it is my pleasure and a privilege to invite Dr. Jayatissa to present her presentation on the medical nutrition therapy in cancer. And Dr. Jayatissa, to you. Thank you very much.
Thank you, Dr. Madhagadara. And first of all, I would like to thank Dr. Madhagadara for inviting our association to join with you, as well as Professor Sudhir Kalupahan. I think he initiated this Zoom meeting, and he did a lot of hard work of coordinating and doing the work. So if I start from the I thought that cancer will be the very hot topic these days, and it is a good time to really think about the medical nutrition therapy in cancer. First, I thought that I should really give a things about the malnutrition, because we have a historical definition of malnutrition. So all of us, when we thought about the malnutrition, we think about the kwashiorkor, marasmus, and the protein energy undernutrition. But in the sense, when we really look at malnutrition, that is not the one. I don't know what is something happened. Sorry. What is, when you take the definition of the malnutrition, that is a state of nutrition in which we take the deficiencies, excesses, as well as Dr. Madhagadara has mentioned, the imbalance of the energy, protein, and the other nutrients. So which will be giving some measurable adverse effects on body function and the clinical outcome. So when we look at in Sri Lankan situation, 1 in 4 Sri Lankan patients had malnutrition on admission. So this is and the other thing is, when they are malnourished on admission and during the hospital visits, they can stay in the hospital, it will get aggravated. And then when you look at cancer patients, and according to our data, the 1 in 3 Sri Lankan patients cancer had malnutrition on admission. So we all of us know during the process of the treatment, it will get and the prevalence is getting more and more. So when we look at the nutrition status and the cancer outcome, mainly that it has a poorer overall survival in the various malignancies. There are so many studies have been conducted, and they shown that survival rate is really have a giving the very poor survival rate. At the same time, it will reduce the benefit from the surgical and medical therapies, because this is very important. Some cancers, it go to the surgical treatment, some for the medical treatment, but these therapies benefit will get reduced. At the same time, the chemotherapy and the poorer tumor response to the chemotherapy, this is also very important, because whatever the things we do, the chemotherapy, if the response is poor, that it is one that we have to always think about. And the second one is always patient complain about the second cycle of chemotherapy, they get a lot of complications. So the studies have indicated that increased chemotherapy related toxicity when they are the poor nutritional status. At the same time, all of us, I think, know the thing is, fact is the poorer quality of life. So these are the kind of overall kind of cancer outcome and in relation to the nutritional status. And then when we look at the malnutrition, and the weight loss, this is very common in most of the cancer patients, and which will really attribute it to many causes. When we look at the causes, are the one of the things, its obvious reason is the decreased dietary intake. At the same time, they have increased nutrient requirements and the impaired nutrient digestion or absorption, and they get the increased losses of nutrients. So all these things will attribute it to the malnutrition in cancer patients. At the same time, they have get the unintentional weight loss also. So because of the unintentional weight loss, it will lead to the decreased quality of life and the poor prognosis. And most of the research has indicated malnutrition occurs about 40 to 80% of cancer patients, and it is one of the major morbidity and mortality in patients with advanced disease. So this shows that how important nutrition in the cancer therapy. So when we look at the common treatment related side effects that which really negatively impact on nutritional status, and in the 3 different stages, like during the chemotherapy, radiation, and the surgery. So you can see that some of the symptoms like weight loss, fatigue, nausea, vomiting, all these things, all 3 are related to the all chemo and radio and surgery, all things. And the taste alteration, oral mucositis, constipation, diarrhea, dry mouth, loss of appetite. These are the kind of very common things which happen during the chemotherapy, radiation, and in the some with the surgery. They really have a kind of negative impact on the nutritional status. So when we look at the type of weight loss, which is something very critical with the survival in the cancer patients, and especially the malnutrition, with that we know the weight loss. And another important thing is a muscle mass loss. So muscle mass functions are kind of thing, we know that muscle mass functions are skin integrity, immune function. These are really needed for the healing and repair, and the GI integrity and the digestion. So when we have a loss of lean body mass, what happens is that it will really greater the toxicity and the shorter the survival. At the same time, that shorter survival times are among the, especially with the patients who are having the sarcopenia, and especially with the obese patients with sarcopenia. And the research have indicated that the median survival of patients with the low muscle density compared with the high muscle density is 14 versus 20 months. So which is something very statistical significant finding. And it really show muscle mass loss is really directly related to the survival of patients. Then the next one is we have to really think of the importance of the nutrition screening. So usually that when we look at the nutrition screening in cancer patients, so most of the time that, I mean, very few people like Dr. Mathagadara kind of think about nutrition, but a lot among the medical practitioners, nutrition awareness is low, as well as they don't much consider about the importance of the nutrition, and because they mainly concentrate on the cancer therapy and the things that nutrition is after the cancer therapy, it will go away. And the other thing is, and I think in the medical school, we don't have much very good education about the nutrition, especially the clinical nutrition component. But patients and the families, they are very worried about the nutrition aspect of the patients, and they come quite often and ask a lot of questions. So as a result, what they do is they use a lot of herbs, supplements, pills, as well as some alternative treatments. Those are the things they go behind with this type of other remedies. But when we take the medical nutrition therapy, which will really improve the, especially with the intensive nutrition therapy, which will improve the body weight and the lean body mass, at the same time hand grip strength and the physical activity level and the performance status and the dietary intake, and then response to and the tolerance to the treatment, which is very much important with the cancer patients. And at the same time, they reduce with the intensive nutrition therapy, which will reduce the rate of complications and the morbidity. When we really look at the goals of the medical nutrition therapy on the cancer prognosis and the expected survival, so we try to, I mean, these are kind of new guidelines and the released from the European Society of Parenteral Nutrition and Enteral Society. They have really indicated 3 aspects of the thing, like pre-cachexia, cachexia, and the refractory cachexia. So they, under the pre-cachexia, they indicated that the weight loss, if the weight loss is less than 5%, but still the patient is having the anorexia and they have a metabolic changes, then the treatment remedies, they have to go for the nutrition council, but still that they need the kind of oral nutrition supplement at the sometimes to include in the anti-inflammatory ingredients, and then the fortified food, especially but the some micronutrients are very important for them, then it's better to go for the fortified food. And the second category, cachexia, and they have a weight loss more than 5%, or if the BMI is, if it is less than 20, and then the with weight loss more than 2%, or sarcopenia with weight loss more than 2%. So these are the kind of things which has been categorized in the cachexia list. But that category, they need oral nutrition supplements. At the same time, they need the adequate energy and protein, that which is very important. At the same time, including some anti-inflammatory ingredients. Then the third category is they are catabolic, but no response to treatment, and expected to survive only less than 3 months. So it's a refractory cachexia group, and they need the palliative nutrition. And because we have to, it should be needed to alleviate their feeling of hunger and the thirst. So we don't need to do the aggressive nutrition, intensive nutrition therapies. So what are the steps in medical nutrition therapy? So first thing is we have to do the early nutrition screening in the course of cancer treatment. And then the early identification of signs and symptoms of anorexia, cachexia, and the sarcopenia, which has to be done as early as possible. Then early detection of malnutrition or lean body mass, this loss, which can be really do it with the kind of CT scans and the some imaging technologies. And then look for the relevant biomarkers on the, especially for the looking at the severity of the cancer-related systemic inflammation, like doing CRP and the albumin. These are the important biomarkers at that time. Then we have to estimate the personalized energy and the protein needs, then to provide the nutritional and the metabolic support. Because so many studies have shown that reducing the inflammation and the restoring lean body mass is very important for them to, as a support. Then assess the physical function routinely to monitor and guide the physical rehabilitation. So these are the kind of very basic steps that we have to follow in the medical nutrition therapy. When it comes to the other component is the energy requirement. Usually these patients, they need about 25 to 30 kilocal per kilogram of body weight per day. And especially these some patients that they are kind of in the severely malnourished patients. So we have observed about 9% of the, about 9 to 10% of the cancer patients are severely malnourished. So those patients that we have to start the feeding very gradually to avoid the refeeding syndrome. Otherwise, it will be very detrimental for them, and then change the energy needs. It should be based on the type of the treatment as well as the rehabilitation. It may be chemo or maybe radio, so those things. Then we have to adjust energy from the fat to carbohydrate ratio, because which is very important. Metabolic changes occurred in cancer patients. Then it comes to the protein requirement. That actually they need the higher protein content, because usually normal people need about the 0.8 gram, but they need about the 1.2 to 1.5 gram per kilogram per body weight per day. So this is maybe due to their higher depletion. At the same time, they have to look at the good quality protein, that not the kind of very vegetable kind of protein. They need the kind of all the amino acids should be in that protein. At the same time, there are some about the important with this branch chain fatty acid and the other amino acid and the metabolites. Those clinical data is still insufficient to give the conclusive findings. At the same time, the glutamine supplementation, it is important in the some aspect, but especially to prevent the gut atrophy and the decreased mucositis and the infectious complications. These are also still need a lot of data to prove it. Then the other major component is the micronutrient and the fluid requirements. That is very important. Everybody always forget about the vitamins and the minerals, and they need about at least physiological doses to meet their daily allowances of the multivitamins and the multimineral supplementation. At the same time, if they don't have any specific deficiencies, they don't need to get the high dose of micronutrient supplementation. This is very important because it's not necessary to give the high doses. Sometimes giving the high iron and things, it will really act in the harmful way rather than in the good way. And the other major component is adequate fluid. These are the kind of other supplements we have to consider about, and the one thing is entry fatty acid, especially with the patients that who are having the advanced cancer on chemotherapy. They are at risk of weight loss or malnourished. Providing the fish oil 2 grams per day, that it has shown that it will improve the appetite, oral intake, and the lean body mass, as well as the body weight in patients with the advanced cancer at risk of malnutrition. So these are the kind of benefits with the entry fatty acids. Other supplement is immunonutrition, especially oral or enteral immunonutrition. It is recommended in the upper GI cancer patients who undergo in the surgeries, and mainly the pre-surgery and the post-surgery. Especially these are beneficial in the chemotherapy-induced mucosal inflammation, vomiting, diarrhea, and the cytopenia. And the third supplement category is probiotic, and there are inconclusive evidences in the supporting the probiotics, especially in the radiation-induced diarrhea. The prophylactic effect is, the evidences are very inconclusive. And the other one is, I think, very famous one in currently everybody is doing the ketogenic. That is another one with the high fat, adequate protein, low carbohydrate diets considered as safe in cancer treatment. But the compliance is very challenging with that type of diet, because these are very highly restricted, kind of very highly different diet. So the next one which comes is the feeding options, and what are the kind of options we have to use in these patients. And the one is oral feeding. If they are able to do, then we have to go for the oral feed, and especially it may be the normal, regular or fortified food, but they have all the problem, mucositis and the taste problems and the altered smells and everything. So we have to always look at the selective taste steering and the texture modified food. These are very important with this patient. And then if the things are not working, then we have to think about the oral nutrition supplements. And the second step is, if they are unable to feed with the oral feeding, then we have to go with the enteral nutrition. It may be short term, if it is, and then we can do the NG and NJ feeding. But if it's a long term, definitely we have to go for the PEG and the PEG and the jejunostomy and the thing. So this is very important, because most of the time that the people will really get delay in inserting the PEGs and things, so it will really affect the patient's overall prognosis. And then otherwise, when the oral feeding, enteral feeding all are not possible and not getting the required amounts, then we have to go for the parenteral nutrition. So it may be supplementary, or sometimes the total parenteral nutrition, maybe from the central catheter or peripheral catheter, or sometimes combined. So these are the kind of feeding options have to really think about, depending on the patient's type of the patients, and whether if they are not getting their needs, daily needs of the nutrition, we have to think of adapting these options. So let's see the palliative cancer care. So when we look at the palliative cancer care, there are 3 phases. One is the disease-focused palliation aimed at prolonged survival. Other one is symptom-focused palliation aimed at alleviation of symptoms. And the third category is the phase of dying. So you can see in this picture, and the first category, we have to really look at that they need the diet meeting all the nutrition requirement that I have mentioned. So it may be through the whatever the oral or enteral or route. Then the third category, symptom-focused palliation, then we have to do only the comfort feeding. And then the phase of dying, that one, that's palliation in the dying phase, that there's no nutrition, you just give the things just to maintain the hydration and the things. So that is with the kind of during the palliative phase. So with that, I think with my last slide and whatever things take-home message is early screening of all patients with cancer to identify nutritional risk in their course of care and provide appropriate nutrition therapies essential. So once again, I would like to thank all of you as participants, as well as Dr. Madhagadar and the Professor Sudhira for organizing it. Thank you.
Thank you very much, Renuka. It was very informative lecture. And I think that this information was very, very helpful to all the clinicians, as I said at the beginning, because this knowledge is mandatory for the management of the chronic patient here, mainly the cancer. This aspect, all the clinicians, I feel that need to give a due attention about the nutritional state of the patient and thereby upgrading their nutritional state. That will invariably going to help to reduce the morbidity as well as the mortality and the consequences related to primary diseases as well as secondary problem which will going to get the patient because of the nutrition deficiency. And once again, I'm thanking behalf of the Kandy Society of Medicine and helping us to conduct this, and Dr. Renuka Jase. Thank you very much. Other aspects of, as I said at the beginning in the introduction, the obesity in pediatric age group are one of the biggest problem, where the Professor Vikram Singh has done a lot of studies on obesity in childhood and has given the oration recently in the Endocrine Society of Sri Lanka about the obesity. It is my privilege to invite Professor Pujita Vikramasinghe, a senior professor, the Department of Pediatrics, the Faculty of Medicine, University of Colombo. Professor Vikramasinghe is going to talk us on management of childhood obesity. So Professor Pujita Vikramasinghe is going to present now.
Good evening, everybody. Actually, I first of all wish to thank the KSM as well as SLMNA for inviting me to talk on this topic, which all of us know it is a quite timely as well as important topic. So without further ado, I would get on with my lecture. And so as we all know, it is all over the world. It is spreading at alarming pace, not as much as COVID, of course, but of course at a fairly large pace. And if we look at the rate in Sri Lanka, also, although nationally we have very as nationally the figures are although low, we do see urban metropolitan area rates, overweight and obesity hovering more than 10% in any given time. So if we get into the technicality, actually, obesity is not actually having a large BMI or body weight. It is actually having a large amount of fat that would be associated with adverse health outcomes in a person. So in the world, of course, it has been mapped out to be roughly about more than 25% for adult males and female 32%. And for Sri Lanka, we have worked out to see roughly about 28.6% for males as well as 33.7% for females. This is 5 to 15-year-old children. Now, practically, it is not possible to measure a fat in an easy manner, although some of the equipment have now come out, like the bioimpedance assay. But for that, what we have to do is we have to use the BMI or weight for height chart as a surrogate marker for the body mass index. Now, if we look at the cutoff values for children for under 5 years, we use the yardstick of weight for height, and above 5 years, we use the BMI. For overweight, in the weight for height, it is +2 to +3 standard deviation in the weight for height chart, which is available in the CHDR, whereas obesity is more than +3 standard deviations. So when it comes to BMI, of course, it is 1 standard deviation below that cutoff value. That is +1 to +2, we take it as overweight, and above +2, we take it as obese. Now, just for familiarization, you would have seen this chart in the CHDR, where the dark purple area is actually overweight between +2 to +3, and above this area is obese, which is above +3. Then for children above 5 years or 5 to 18-year-old children, we take overweight between +1 to +2 range, and then obesity above +2 range. So that is how we first enter into the diagnosis of obesity. Once we have done that, we can embark on that. But I would also like to make a comment here that once we get the weight for height or weight for or BMI values, we always may have to have the charts, because children, we can't get a single cutoff value, and with age as well as the gender, it changes. But of course, a rule of thumb or a very simple, straightforward measure is the waist circumference to height ratio, where when we measure the waist circumference, that is the midpoint between the lower point of the costal margin and the highest point of the iliac crest in the mid-axillary line. And when we measure horizontally, we can get the waist circumference, and it should be ideally below 50% of the height. Now, because we all know obesity now, as I said, it is the fat mass that is associated with illnesses, illnesses is the diagnosis or the definition of obesity. And this fat is actually the abdominal fat, which is mainly responsible for all this morbidity. So knowing that exactly in an indirect manner is very, very helpful. And waist circumference to height, which we have validated for this country's children, has shown more than 0.45 actually, but as a rule of thumb, we can take 0.5 as a cutoff. If it is more than 0.5, it is not quite healthy. So that is a quick measure that can be done at any point, any person, and irrespective of the age or the gender, that cutoff more or less remains as 0.5. So having said that, now we all know that obesity is an illness which can be leading to cause many health problems. It can start from head and end from the toe. And it can be mechanical problems, it can be metabolic problems like that. Or even it can be psychological problems, which is especially leading to a lot of adverse outcomes in childhood population. Now, out of these two main problems is non-alcoholic fatty liver disease as well as the insulin resistant mediated metabolic syndrome. So, So diagnosis of metabolic syndrome is actually, is actually based on a criterion diagnosis, because IDF has given us a consensus definition in the recent past, and what we use is waist circumference as the absolute criteria, and 2 out of the other 2, that is dysglycemia, hypertension, elevated triglyceride, or reduced HDL level. So that if any 2 of those, that is having a waist circumference plus 2 of the other 4 metabolic abnormalities, namely hypertension, abnormal glucose metabolism, that is it can be either impaired glucose tolerance or diabetes mellitus, or elevated triglyceride levels or reduced HDL levels. So any 2 out with the waist circumference more than the stipulated value, it will be, you can diagnose metabolic syndrome. When it comes to non-alcoholic fatty liver disease, the NASH is the worst condition where non-alcoholic steatohepatitis has occurred. And actually for that, we have to have a biopsy ideally to diagnose NASH. But it is not practical to do a biopsy in each and every child, and especially when we are following up. So ultrasound scan has been validated now, and it gives a good, clear understanding about the level of or the degree of fat deposition in the liver. And then if there is a enzyme derangement, that will be helpful. So if the ALT, AST is elevated, then of course we can take it as that there is hepatitis. But the hitch here is whether it is alcoholic or non-alcoholic hepatitis is what we have to identify. So in non-alcoholic hepatitis, the ALT level is always higher than the AST level. So ALT to AST ratio, if it is more than 1, then of course we can take it as having quite confidently it is non-alcoholic steatohepatitis. So if these two are there, that is on ultrasound scan, there is fat deposition in the liver, and biochemically ALT to AST ratio is more than 1, then we can make a diagnosis, and to be on safe side, what we call it as a presumed NASH, because by the correct NASH, of course, can be diagnosed only by a biopsy. Now, one of the most important markers which we come across in clinical practice is the suspected metabolic syndrome. And then how can we do that is seeing acanthosis nigricans. This is, of course, a darkening skin around the neck, maybe armpit, or cubital fossa, or in the groin. Now, this is actually not a discoloration. It is actually hypertrophy of the melanocytes. And you can quite clearly see here that there is a 3-dimension into this. So depending on the degree of insulin resistance, this is much more severe. And although there is no definite grading system, but the good thing about this is with the reduction in the insulin resistance, that is mainly by reducing the fat content of the body, this will come down and it will even disappear. So this is a personal incentive for the person who is following a strict dietary physical activity plan, and this even without doing any biochemistry or weight measurement, we could confidently say, okay, things have fairly improved. So this is a good marker for the clinical follow-up of a patient. Now, it is important actually to identify the origin of the obesity, although majority, more than 95% of them are nutrition. But of course, we also should bear in mind that it could be part of a other endocrine or syndromic, and usually they are short obese. So when we say short obese, that the height is usually below the median, whereas the weight is, or the BMI is well above the median or the +2 standard deviation cutoff value. So then of course you will also come across typical pathognomonic or associated features to diagnose them either into a syndrome or an endocrine illness. On the other hand, we get the other category, the tall obese, that is their height will be in a higher level, that is above the median, maybe +1, +2 range. They are growing according to their possible genetic ability or the growth potential which is inherent, but their weight is surpassing that, so they become obese also. So this is mainly actually nutrition related. It could be either a predisposition for them to consume more energy, or they are preserving more energy in the body. So one thing is the single gene disorder on congenital leptin deficiencies, or it can be associated with valproate intake, physical disabilities where the expenditure is less, or adolescents on IDDM who are taking insulin, which they will be taking with indiscriminately just to be with their peers and eat without any hindrance or any psychological problems. But the majority what we see is the nutritional, pure nutritional, due to increased calorie retention. That is, they are taking a large amount of calories. Their consumption of the calories less because they are physically One thing is they are not engaging in enough amount of exercises, and on the other hand, they are spending a lot of time without doing much activity physically. That is high sedentary behavior, that they spend seated for long hours without doing much of taking much of physical effort. So what do we do? So now we have diagnosed obesity. We have found out whether it is purely due to nutrition or whether it is part of another illness. But overall, what we have to do is we have to manage them. So reduction of the weight is very important, and treat any morbidity is also important, and psychological adjustment, because this is a behavior problem. And it is psychological adjustment may not be only for the child, but for the whole family, because if the other people are also adopting a wrong eating behavior, physical activity behavior, then naturally the child would also get pushed into the same stream. So reduction of weight, of course, in the prepubertal, if the weight is not very high, it is closer to +2 standard deviation in the BMI chart, then of course, managing the weight would be a initial step would be better and much more achievable. And then of course, if they can lose weight, that is good, because the whole reason is that the pubertal growth spurt would be coming very soon. And if we can maintain the weight without letting it increase, then the height will take over and the BMI would settle into a lower level. But of course, the weight is, if it is very high, that the BMI is more than 3 standard deviation, and especially if they are peripubertal or postpubertal, then of course, weight reduction is fairly important. Then there can be other associated morbidities like hypertriglyceridemia. There can be type 1 diabetes or type 2 diabetes or pre-diabetic states. Then of course, individually, those have to be dealt with. So as an initial step, when we diagnose a child with overweight or obesity, we could do a simple basic investigations where after 12-hour overnight fast, we could do a fasting blood sugar, lipid profile, ALT, AST, and then we tend to do a glucose tolerance test. Of course, we have to give 1.92. This is actually 1.75 is anhydrous, but this is monohydrous, which is available in the market. Monohydrous glucose to a maximum of 82.5, and only the 2-hour RBS value is sufficient. So once we do that, we can say, because this is, I prefer OGTT much more than the fasting blood sugar, because it really gives after the what is the body is doing after a full measured amount of a challenge. So if the challenge can be negotiated, that means his glycemia is okay. But of course, if it is not so, then we may have to take action. Then the lipid profile will also help in making the diagnosis of the metabolic syndrome, where I could give the triglyceride level as well as the HDL. And then the ALT, AST as well as the ultrasound scan abdomen will help us to identify fatty liver disease, of course, which is there more than 20% now in obese children in this country. And the good thing about all these are, if you can manage the weight in the initial phases, you can prevent a lot of morbidity occurring in the childhood population. Now, overall management, when you say, okay, behavior modification, change in the dietary pattern, that is one of the prime important things. Then change in the activity pattern. Now, we don't talk really actually of increasing physical activity. We talk about changes in activity pattern. So that is increase in physical activity. And it is very important to reduce sedentary behavior and regularize sleep, because sometimes what happens is people will engage in 2 hours of physical activity. But if they spend 10-12 hours in sedentary behavior and they deprive their sleep, that would be counterproductive. So it is very important that we have these three managed quite efficiently to get a better health, and then also to provide the psychological support. Pharmacological agents are available, and metformin is actually have shown a lot of promise, and there had been about 2 reviews which have come up recently recommending the use of metformin. And in my practice also, after about 3 to 6 months dietary activity And if it is very poorly responding, then I put them on metformin. Or if they have impaired glucose tolerance, then of course, again, I start them on metformin, because metformin helps on two ways. It improves on the metabolic profile by reducing the insulin resistance, as well as it helps in reducing the appetite and initial diet restriction. Then of course, surgical treatment, although which we are not using extensively, but of course in morbid obesity, and especially in older ages, somewhere around 15 plus, this is now emerging even in Sri Lanka. So diet, of course, you have to give a plan, and we have sort of based on portion sizes, we have been advising the children, and based on the main food groups, and that way they have been able to get a good idea about that. And we give a list, because we don't like to give a prescribed. It is not possible to give a prescribed diet for children or anybody actually. So because their food is not only for nutrition, it is a recreational thing. It is closely related with the culture. So we have to allow people to eat, and also what is available they have to eat, not what we are prescribing and what is palatable to them. So we give a list of items and tell them, okay, these are the amount what individual portion means. Then we tell, okay, for the age, for the activity, depending on the state, we say this is the number of portions one should be taking from one of these, from these individual groups. So a mixture of that, and the total number of portions from each group should come to the prescribed amount. So that way, of course, those who are well motivated, those who get the good support from the household, we have seen quite remarkable improvements in their body BMI as well as the body composition. Now coming on to the 24-hour movement guide, it gives the three main things. As I said earlier, you can have the physical activity, but if the sedentary behavior is large and even encroaching into the sleep, then of course it is going to be counterproductive. And sleep, which we have taken it for granted, is actually now, there have been a lot of research in the recent past showing that how sleep is important. And what they recommend is for any person, whether it's a child, whether it's an adult, 10 p.m. to 4 a.m. is the ideal time for anybody to have a nap. And you can see even for adults, it is about 6 to 8 hours a daily sleep is recommended. And you can see from age, younger the age, more the sleep duration is needed. And for about a school-going child, roughly about 8 to 12 hours, depending on their age, we have to provide them sleep. But of course, with a lot of screen devices and things like that, there has been reduction in this time. And also the habit of sleeping at any time of the day to compensate or accumulate is the practice. But of course, research have shown it is not, there is a particular, because we are not nocturnal animals, we are diurnal animals, and evolutionary, we have been sleeping at night but active at daytime. So there is a lot of benefits from sleep, which I'm not going to elaborate now. But of course, there is something called good sleep or sleep hygiene. That is definite to have a proper time of going to sleep, a regular time, and to have a regular wake up time, which is very important. And then to avoid any material that would hinder sleep, like coffee and things like that. Then a wake up to the natural light would be a better thing. Anybody should not go to bed hungry, that they should have a good meal and go. And then they should restrict all screen devices in their room, not televisions, no handheld devices. Then of course, exercise, regular exercise will also improve the sleep to a great extent. So those are some of the important things. And if somebody wants some relaxation before going on to getting sleep, of course, what is recommended is to read a book. So where the slogan of brush, book, bed has come into practice now in the Western world. So having said about diagnosis, then the basic management of childhood obesity, I thought it's also important to touch on prevention, because prevention is always better. And this is some of the things that changes, because majority of childhood obesity ends up as adult obesity. And many changes in the body, the upper body, lower body, the stomach, the abdominal sagginess, all these things will persist. And sometimes when these children in their younger age, they are so want to eat and they can't put on weight, and sometimes parents think, okay, later on they can reduce weight. But of course, quite clearly we can see that although they may transiently reduce weight, still most of the stretched skin changes, that is the sagging breast, the sagging anterior abdominal wall, will never return to its normal level. So it is always better to have a skinny body during younger age, because you can at any time increase the size, the weight later on, but not the reverse. So the ending childhood obesity WHO report came up with 6 main points. But what I want to do emphasize in this case is actually to strengthen the growth, because definitely having a good size child is important. So maternal nutrition is very important. And then early diet and education at school, then weight management, proper nutrition, and physical activity. So out of that, I think what is one of the most important thing is childhood correct diet. And many people think in this country, especially, that eating the limit of growth is the sky is the limit, and they just keep on. If the child is eating, it is our culture also not to hinder somebody, not to stop somebody who is eating. But of course, it has come now to a point where we have to limit the amount of food which we eat. So one of the important thing is that we monitor the growth chart and we see this trajectory. So if they are nicely going parallel to, or from where the point they started, whether it is a very small baby or not, it is fairly okay, provided that the development as well as immune functions are perfect in the child. But the one which we have to observe is the one who keeps on crossing and going up. Now everybody's mind, people will be very happy to see this line denoted by C going upwards, because traditionally we have said -2 to +2 is the normal range of growth. But of course, whether this is a natural catching up of whatever the child maybe have missed, or whether it is going in a wrong direction, is what we have to see. So one of the most important thing is that we have to see the trajectory and then we have to plot them. So if you look at these two, a child who started here in the just below -3, going up, crosses -2, -1, and then the median line has come up to the area between median to +1 in the weight for age chart. And somebody who has had a very large birth weight went on, crossed only one standard deviation line and came. So looking at these two, you can see this line A had kept on crossing about 4 levels, whereas B had crossed about only 1 level. Now what we always want is, we want to standardize this to the height of the individual. So in children under 5 years, I said it is the weight for height and not the BMI. So it is very important that once we see this, we plot also the length of the individual. So you can see what has happened for the length of the individual, and then you will plot them on the weight for height or the weight for length chart. And in this case, you can see although A kept on crossing several lines, he has maintained between median to +1 level. So this is not bad. But of course, there were minimum crossing of this person, but he had an optimal length also, because when A kept on growing in weight, he kept on also acquiring length also. So as a result, he maintained his weight for length ratio. But of course, B went beyond the level and had a excessive weight compared to his length. So this is very, very important, because we had been always only concentrating on the weight for height or weight for age chart, and then based on we were deciding. And especially when there is upward trend, you have to always see whether this trend is a correct one or not. So it is always using the weight for length and or the weight for height chart is important at least once in 3 to 6 month interval, because otherwise the weight height will not give a sizable change for us to measure. And in the first year, every 3 month weight height measurements, and from the second year onwards, at least every 6 month height measurement is very important. And then plotting this and picking up early upward deviations of obesity is very, very important if we are to correct or prevent the obesity development. So then another quick thing about this catch down phenomena, especially in diabetic mothers, any child who is above 3.5 kilos, there is a higher chance, in my experience, it's more than 99% chance, then to be having some form of a gestational diabetes. And these children can't grow. And if we try to make them thinking that the mother is not having enough milk and try to put them on a formula and try to get onto this, it will be very detrimental. So this initial drop in the background of gestational diabetes or a strong family history of maternal side diabetes of the mother will have a large baby, and then within the first 2 weeks or so, this weight will drop, settle onto a centile, and then moves on that centile, and we have to respect that. We should not correct this, especially in a mother's baby who was having gestational diabetes during pregnancy. So why we have to correct this? Fat cells begins in number to increase from birth up to about 20 years or so, and then only static. So if there is large number of fat cells, when they are entering into young adulthood, that number cannot be reduced. So keeping them here is the best thing. And then if they want, they can really increase the size of the cells and come somewhere here, but not going into the obesity. So that is where childhood obesity prevention is very important, because you are preventing the number of, or minimizing or restricting the number of fat cells which you are going to have as an adult. So if there is more fat cells, more opportunity to deposit fat. But if there is less fat cells, then less opportunity to deposit fat later in life. So that is where more than 75% of the obese children become obese adults, and less than 10% of normal weight children become obese as adults. So effective intervention to control obesity is very important, and for all children, we have to work towards a common goal. Thank you.
Professor Vikram Singh, thank you very much for very excellent presentation and updating the knowledge about the current status and the modern concept of childhood obesity and all practical information regarding the childhood obesity. Once again, I want to thank you on behalf of the two societies. Now, our third speaker, Dr. Ranil Jayawardena, is a clinical nutritionist and the senior lecturer, Department of Physiology, the Faculty of Medicine, University of Colombo. Dr. Jayawardena is going to talk on the other aspects of the obesity, that is the obesity in adults. So he's going to talk on the update of management of obesity in adults. Dr. Jayawardena.
Good evening, everyone. And first of all, I must thank Professor Sudhira Kalupana for inviting me and the organizing committee from the KSM and SLMNA for arranging this wonderful webinar. And this is the first time I'm appearing in the KMS, so I'm quite excited also. And the topic today is about update management of obesity in adult. I'm not going to discuss about any guidelines or any other clinical trials or anything, but here I am going to share the Sri Lankan evidence to handle the obesity, but most of these evidence are very recent. Probably you haven't heard these things. And yeah, and So today I'm quite excited to discuss about the subject of management of obesity in adults, but mainly I discuss about the Sri Lankan evidence because obesity is a lifestyle disease, and sometimes guidelines in other countries may not be directly applied for the Sri Lankans. So probably you will not see any magical drug at the end of this presentation, because actually, apart from the bariatric surgery, obesity management is extremely difficult and failure rate is very high all over the world. But this is a very important area. I share one study to show the importance of this area. Exactly 3 years before, we did a national survey on the weight loss supplement in this country. So we found actually 100 supplements during that 3 months period, and surely numbers has increased now. So it shows it has become a real medical problem for this country, and there are various treatment strategies here, but they are not very effective at the moment. So outline of my presentation, I'll discuss a background of obesity. I think other previous speakers also justify this. And then a couple of fat diet, because that's a common question always asking these days about the keto diet and intermittent fasting. But it's mainly what we believe. We have to understand Sri Lankan dietary habits to give the proper advices. So one of our creation for the medical faculty Colombo is about the plate model concept. Then I'll discuss about the evidence behind that and how we can apply for our patients as well as for our lives also. So that concept won't be very technical thing. You don't want to be like an obesity expert to apply that. Any medical doctor, even other health staff can use this. So there's no argument now. Obesity has reached the epidemic portion in this country. This is national level service done 2005. It's almost like a 15 years before. And then I revisit some sample almost 10 years before. And thereafter, a few other surveys are done by the different groups like Dr. Renuka Jatis and Sudhira Kalupahana, Dr. Novel Somasundaram. And they all found now we have an epidemic of obesity in this country. So the question is there. So we need answers for that. And I would like to share another recent evidence. And as we know, being a South Asian, we have a less muscle mass and more fat mass. But we didn't have any body composition data for the adult sample. Of course, there was evidence came from the Professor Pujita's studies for the pediatric sample. But this is the first time we have like a cutoff for the BMI cutoff for the adult sample. And we found it's quite safe to use the BMI 23 to identify the overweight and 25 to identify the obesity. And most of these patients needed a lifestyle change. So even you falsely identify someone with a more muscle mass and claiming that person is obese, but there won't be any harm of giving a dietary advice. So that's just another update or another message I want to give in this presentation. We should use a local cutoff, and we should be quite low value. Probably international cutoff may not be very accurate for Sri Lankans. And this is the question I'll be always asking when there's that providing dietary advice for the obesity, ketogenic diet. This is not something well new. This has been practiced from like the 1920s for the epileptic patients. So what is the main physiology behind this? Actually, you are retraining your body to use the fat as a male's primary energy source, while at the same time reducing blood glucose level and insulin. So what is the basic physiology behind this? Actually, initial quick weight loss is due to a water depletion, because if someone do not get adequate carbohydrate, they lose their glycogen stores and whereas oxygen also, water also. Then, although these high fat diet, high protein diet look tasty, but when someone's eating that food for the longer period, they reduce their satiety, then they reduce their food intake as well. So ultimately, it becomes a low calorie diet. But we don't encourage this diet. The reason it may increase cardiovascular diseases, and it's very expensive. It's not very cheap eating a sausages or cheese or eggs are not very cheap in this country, and it is not practical in Sri Lankan context. You will be seeing in my future slides also, because most of our dishes are made from the carbohydrate. So, for instance, like a milk rice or string hoppers. So it's very hard us to cut down carbohydrate in Sri Lankan context. So this won't be very effective in the long run. Although they can lose in the beginning, but again, it's very hard to maintain the weight loss, which is the most important part of the weight management, not the weight loss. That's another message I want to tell you. Weight loss is not an achievement. It should be mainly the maintenance. To maintain the weight loss, it should be very close to their routine dietary advices. So which I'm going to discuss in the lateral part of the presentation. Another one, the intermittent fasting. That's nothing new again. If you know the history of this, most of religions, they do the fasting. This is a very common habit for the many religions. Even Buddhist monks, they fast probably 16 or 18 hours. So what these people do who are doing intermittent fast, probably they fast whole one day for once or twice a week. And for some patients, they limit their food intake to a very short period, probably 8 hours, and they fast for the other 14 or 16 hours. Then it's just very simply, they can't eat everything within the short period. So they lose weight because mainly the calorie reductions. But there are many downfalls of this also, because when you fast, you don't get any food. That means you don't get calories as well as essential nutrient also. So there will be a chance to get nutrient deficiencies. And when someone's fast for the longer period, that break down the muscles and reduce the metabolic rate. And again, it's not practical for the long term, because weight maintenance is not possible with this kind of strategies, because once they start eating, since their metabolic rate is lost or low because of this intermittent fasting, they try to catch up what they lost. So actually cause of the obesity is due to positive energy balance. That means if someone is getting more energy from their food than energy expenditure, that excess will be stored. So it's simple as that, because we can't create or destroy energy. So excess energy will be the storage. So if we can reverse this mechanism, that means either we can cut down energy intake end, or either we can increase from the energy expenditure end or energy output end, we can be successful. But cutting down food is easy compared to expending energy. For instance, even normal adult who walk 1 hour can burn like 200 calories. Not a lot. Those treadmill values are not very accurate, because those are not validated for the South Asians, where we don't burn much calories. So food intake end is the easy way to make a negative energy balance. That's in other words, if you cut down food, it's very easy to go through the negative energy balance compared to increasing physical activity and burning calories. For that, we need to know about energies. But it is not possible in Sri Lanka. This energy deficit approach or calorie deficit approach is not practical because of many reasons. We don't have a complete food culture database. I think you already know that Dr. Renuka has taken the national level leadership to make a food culture database, but still it's not available. And we have 100 of recipes in this country. And it's very hard to make a complete food consumption database. At the moment, we don't have any. Another thing, when someone wants to measure the energy expenditure, we have to use these international formulas. They may not be very accurate for the South Asians, because, as I mentioned earlier, we have a less muscle mass and more fat mass. And because of our different body composition, probably we don't burn like Caucasians or Negroids. So this is another limitation. And third limitation, our food labels are not very complete. You can see this is from the very reputed brand, but they have mentioned about the total energy here, but they haven't mentioned even the amount of carbohydrate there. And you will see other way also, there are carbohydrate values, but there's no energy values. So it's very hard to measure or calculate energy using this food label. Unlike developed countries, it's very hard to do like 1,000 calorie diet or 1,200 calorie diet, because we don't know the real calorie value and composition in these food products. And the actually main or biggest problem, we have a different recipes. Now, if you go to Europe, or probably their breakfast is a scrambled egg or chips, or probably the sausages. So it's very easy to get the recipes. But even our simple dal curry has several variations in our ethnic groups, as well as some household differences also. So this thick dal curry have 4 times higher calorie compared to watery dal curry. So it's very, very hard to measure the calorie intake in Sri Lankan context. But we have several nutrition issues. So if you can identify this nutrition issue, the answer also there. And again, I'm sharing some local data. We did this national level energy and nutrient intake survey, but unfortunately, we don't have any real survey. This was like a part of my PhD project. But at the moment, we don't know what we eat. We don't know our food intake. We don't know about calorie intake. So this is only available data. And what we found, irrespective of the gender and ethnicity, area of residence, BMI value, or education level, or age, we consume large amount of calories from the carbohydrate, which is around 71%. And you can see the amount of protein intake also very little and fat also very little. So our main calorie source in this country is a carbohydrate. So if someone want to cut down calories for the individual, it should be mainly carbohydrate. For that consists of over 70%. But if you take a Europe or like England, their main calorie consumption is from the fat. They get like a 40-45% calories from the fat, and another 25% of calories from the protein, and relatively less from carbohydrates. So their advice is very different to us. They ask their patients to cut down fat and protein probably because these are main calorie source. And they suggest their patients to increase the carbohydrate also because that's not their problem. And in addition, we did like a portion surveys also. So those evidence I will discuss here. And now I will move for the Sri Lankan diet because solution will come with if you understand the Sri Lankan diet. What we identified, most of Sri Lankan food does starch, and we consume more than average recommendation. And Sri Lankan average adult consume 14% of a carbohydrate, whereas national recommendation or international recommendation recommend only 6 to 11. Why is that? Because all these rice plate are like this. It's a full of rice and a little amount of vegetables and probably other curries, dal curry or piece of fish or something. So we consume less vegetable and less protein and more starch. And all other common dishes like thosai and rotis, hoppers, string hoppers and bread, milk rice, everything carbohydrate. In this country, main foods are all carbohydrate. And we consume this carbohydrate with very much another carbohydrate. For instance, you may eat string hopper with a dal curry or potato curry, which is not a vegetable or anything. You get a mainly carbohydrate again. But if you check the protein intake, it is not actually a main problem in this country. We consume actually less than recommended amount. We consume around 10% of calories from the protein. It should be around like a 15%. And some of our obesity patients, they cut down protein to lose weight. That may not be very appropriate because protein is not the major source. As well as having high protein in their meals, especially during weight loss period, maintain their muscle mass, which is very important to improve their metabolic rate also. And similarly, fat percentage is also not very high. We consume around 18% calories from the fat. So this is not a country we consume a lot of fat. We have a couple of sources like a coconut milk and other oil types, but not very, very large amount. Probably because we hardly fry things. Most of our dishes are tempered. So you tend to eat less coconut with that or oil with that. So oil is also not the most important part to cut down calories. So it should be always a carbohydrate. So we have another nutrition issue, and we do not consume a lot of vegetables. Vegetables are actually provide very little amount of calories, but there's a huge filling power. So they can eat vegetable, but they don't feel hungry with that. But most of our so-called vegetables are not vegetables, like a potato and all these yams and this jackfruit, breadfruit, everything is not vegetable, but we eat as a vegetable curry. So we tend to get more carbohydrate when they eat these things with the rice. All pulses are pulses, they are not vegetables. They also provide mainly carbohydrate and some amount of protein. So this is another issue we have to handle. During my latter part of lecture, I'll give a solution for that also. So we have 3 nutrition challenges. One is we consume high starch diet, high carbohydrate diet, and we consume less amount of protein and probably low vegetable intake also. So our solution should be for these 3 nutrition challenges. So we have to cut down the carbohydrate, cut down starch, we have to increase the protein, and we have to increase the vegetable to fill our patients. Otherwise they feel hungry. If you control their portions only, they feel hungry. And this is the main take-home message in this presentation. So we can suggest this something called plate model concept, whereas half of your plate should be vegetables, quarter is starch, quarter is protein. This kind of similar method has discussed in other countries also. The first one from the US, they call my plate concept, but it is not practical for Sri Lanka because we don't add fruits for our meal, and this is not the plate actually. That's like a daily consumption. And second one, eat well plate also, but a daily consumption of like a proportion of the food, because we don't eat everything in this plate. And there are local Sri Lankan plate also from the like presented from the Ministry of Health, which is also for the not for the weight loss, for the healthy living, and which also consists protein and the variety, less rice, but still it's not for the weight loss plan. So we decide this method. This is called my rice plate concept, and there are different colors or different codes to identify the food groups. So this red group for the protein, because we consume less protein. So in this concept, we encourage to consume more protein, and which have high satiety power also, so they feel full with the protein, and that may preserve their lean muscle mass also. This yellow color is for the cereal, so it's like a carbohydrate. So it could be rice or pasta or something. Another half for the vegetable, whereas the dark green color for the dark green leafy vegetables in Sri Lankan mallung or like other salads, and the pink one for another pink vegetable, another one for another green vegetable like beans or something. Pink one like example like carrot. So this is a concept I'm going to discuss in the later part, and which all of you can follow yourself as well as you can give this advice for your patients. Why I'm suggesting this? This was recognized in the national level and international level, and this year, early this year, I received the award for the best scientist with best young scientist for the National Science Foundation as well as World Academy of Sciences. And so this is evidence based because we did this plate concept for our patients, and I will share the protocol article. Then very recently we published a full paper also, and we use the post-MI patient because of the my collaborators in the cardiology unit, not because of any other reason. And we recruited 120 subjects there, all are post-MI, and we gave this plate for the 60 group, and we gave a basic dietary advice for the other 60 group, because they always get a routine dietary advice and lifestyle advice for the nurses. So we didn't change that. So at the end, what we found, those who have a BMF over 23 have a significant weight loss, whereas there's a BMI loss also, and which is like over 2 kilogram. It's not a big value though, but what we did was very simple. We gave this plate to them. We asked them to use that plate when they are eating rice, but we didn't change their snacks. We didn't change their milk types. We didn't change their probably breakfast and dinner, which may be other foods like a string hoppers or other thing. We didn't change, but still we got like a significant result. And 1/3 of this group lost 5 to 10% from their body weight, because Sri Lankans are not very big, so even 2 kilogram weight loss is a something for them. So because of this result, I really suggest you to use this plate concept for your patients. And now I'll go for the practical side of that. We already published this as a book also. It is in the common domain. You can buy it for the major bookshops. And now I'm giving like a practical advice how you can use this plate concept for the Sri Lankan food habits. And most of us we eat white rice. So we eat white rice with some bole, dal, curry, some vegetables, some protein like that. So if you want to use this concept, half of your plate should be vegetables. So you have to advise your patients or yourself to have a lot of vegetables, and quart is protein. Here is a fish and quart is rice. This is a quite small plate though, but that advice is not enough at all. So because in Sri Lanka, when we eat green leaf vegetable, we tend to add coconut. Coconut also provides significant amount of calories for our diet. So if they really want to add coconut, they have to add water squeeze and add the remaining part. In Sinhala, it's like a pol rodda, but it's not like a real pol rodda. It should be only one squeezed one. So it has some taste also. Or they can use other methods to make the green leafy salad like a mallu, using onions and tomatoes and other things. Like for example, it's a gotukola mallu or something. They can use onion and tomato rather than coconut. And when they cook this vegetable, we get a lot of oil from the vegetable also because we tend to add thick coconut milk, mitikiri. So you have to advise your patients to add diluted coconut milk. It's something diakiri, but it's not necessary to be like a second milk or third milk. And actually they have to use less amount of coconut and more water, and probably they can blend it. Then they get a diluted coconut milk. So they should use less coconut. And when they eat protein item also, like a fish, meat, it should be fried. But they can have other methods like a Sri Lankan dishes like a malu embultial or malu mirisit or something, which doesn't provide any fat. And that's also not enough. So you have to get detailed advice, because if you start eating from this rice end, you always feel there's a more vegetable, I have to serve more rice. So you have to advise your patients to start from the mallung end or vegetable end, or if it is a salad or something like a cucumber salad or something, they can easily start with that and then mix with the rice and eat it. So that is another advice. And third advice, most of our dishes, our curry are quite spicy. Even you take a beans curry, we add chili there. So when there's a chili, you need more starch to dilute it or mix it and eat it. So that's third advice. These vegetables and protein shouldn't be well spicy. So if it's less spicy, actually they can enjoy the taste of the real food. Now, if you take a carrot curry, we don't know the taste of the carrot curry. We don't know the taste of the carrot. We get only a turmeric taste. So like that, they can cut down the spices to enjoy the real food taste also. So this is for the red rice. Similar thing you can do for the that's the white rice. Similar thing you can do for the red rice also. So there should be a mallung and vegetable. Yes, there should be protein, and quarter should be only rice. Although vegetarian meals are not very healthy in this country, because the so-called vegetarians, they tend to have a dal and sometimes potatoes and sometimes sambole, but they are not having really vegetables. And another problem with vegetarian dishes, they tend to get less protein also, because it's very hard to find protein in the vegetarian dishes in this country. And even though get the protein from some vegetarian food like a paneer and tofu, which contain high fat, so those are not low in calorie. So if they really want to follow a vegetarian plate, so this should be the way. Again, half should be vegetable. In that vegetable, one should be pulse vegetable, like a beans, long beans and wing beans and avara. And other quarter should be mushroom, and this is same mallung. And they can have a soya, and which also what high amount of protein. Of course, it has some carbs also, but that's the only option. But initially, I don't encourage tofu or paneer because they contain a lot of fat and high amount of calories also. Even though it's called rice plate, but we can use for the pasta also. Now in this country, we eat pasta with the cream or oil or something. But this is the way. Half of their plate should be salad, quarter should be salmon or other protein, and quarter should be only starch. And they also can start from the salad end and finish it, and they can mix and eat it. So this goes well with the pasta, because the people who are eating pasta in these Eastern Mediterranean countries, actually, they are having these salads or pink salmon along with that. So it's not a very odd meal because you can't have malum here. So not only for the red rice and pasta, you can do it for the even fried rice. Of course, it contains a little more calories, but if you eat a fried rice like that with the chili paste or some gravy, you end up eating only rice. But if they really want to fried rice, yes, half of their plate should be vegetable chopstick. Again, you have to be a little more detailed. They shouldn't add butter or oil for that. When they're making vegetable chopstick, they can add the soya sauce and probably corn flour to make it thicker. And they can have a chicken devil, but it should be not a fried one. It should be roasted chicken, and they can make a devil using probably not a tomato sauce, probably tomato paste and tomato paste rather than tomato ketchup or something. And fried rice sauce shouldn't be very oily. But again, they have to eat from this vegetable end and then mix it and eat it. This concept actually can be used several other food also, like a chapati. In the North India, we have seen the epidemic of obesity and diabetes because of the eating chapati. All those of wheat, but they eat with only gravy like this, like a dal curry or paneer or something. And they are hardly they eat vegetables. So this is the way. If they want to have chapati, they can make it like a wrap with some protein, and of course with a lot of vegetables like cucumbers and other things. And finally, bread. This is a common Sri Lankan dish, and we love to have this bread. But then we tend to have even a half loaf of bread with a dal curry and sambol or fish curry or something. That's really bad meal because it provides a lot of calories. Otherwise, bread doesn't have any other issues if you control a portion. But if you eat like a Sri Lankan style like this, you will end up eating like a half loaf of even sometimes full loaf of bread. So what is the strategy for that? We encourage our patients to have bread sandwiches, which should be full of the vegetables. And there should be some protein also, like a tuna or chicken or something, but not something fried. But they can have local chicken like a malu ambultial or like a chicken mirisot or something. That's perfectly fine. Or they can go for the international recipes like a tuna or omelette or something there. But again, half of their portion should be vegetable. So this is like in our sandwiches. And if you go to a shop and buy a sandwich like a Perel sauce or something, you will only get like a butter and protein, but you don't get this amount of vegetables. So now I'm the lateral part of my presentation. Although this concept is very good to change the main meals, but patients complain of the hunger in between. So in this position, like a snack is have a greater place. So we need like a 2 fruits per day to maintain good health. So always fruit should be a snack during this diet plan, not a dessert after meal, because fruit also sugar, and our main meal of course is carbohydrate, and then the patient get a higher carbohydrate load also. Probably Sudhira will discuss about the diabetic management after my presentation, but fruits have a very important place in the mid-morning and as a evening snack. And other things like a small amount of nuts also, quite possibly it's expensive in this country, but again, it's like a convenient snack. And cup of yogurt or cup of milk should be another snack in between. So if they can have like a 3 snacks in between, like a 1 mid-morning and probably 2 in the evening, they can easily manage with that plate concept. Then they will get a lesser amount of calorie, and that will lead for their weight loss. So in my summary, and obesity is a major public health problem. There's no argument, and we can't forget obesity. As a doctors, we have to handle our obesity patient in every specialty. And fat diet are not very practical in Sri Lankan context. Even it used for the weight loss, but it's very hard to maintain those fat diets like intermittent fasting, keto diet. So we have to give answer for the major nutrition issues like a high starch diet and low protein and low vegetable. So solution would be, one of the solution is plate model, and which is very practical and surely it reduces the calories and it evidence-based. And it improves their diet also, because it provides vegetables and protein, and it improves overall quality of health also. So thank you very much for your attention. The last message, if you want to work with obesity patient, you have to be a role model like Professor Sudhira Kalupahana, and otherwise they will not listen to us. Thank you. I don't know whether the place for the take questions, but if there are questions, I'm happy to take it also.
Dr. Jayawardena, thank you very much for your evidence-based lecture and its practical aspects, and it's really helpful to all of us for our dietary management. And we will have question at the end of the webinar. Now, my privilege to invite our fourth speaker, Professor Sudhira Kalupana. He's a professor in human nutrition in the Department of Physiology, the Faculty of Medicine, the University of Peradeniya. Professor Sudhir Kalupana is going to talk on the dietary management of type 2 diabetes. And it is a common metabolic problem. Sudhir will talk on the dietary management type 2 diabetics. I'm inviting Professor Sudhir Kalupana to present his presentation.
Thank you very much for your kind introduction. Right. So first of all, I'd like to thank Dr. Madhagadar for initiating this webinar, because his idea was to get this webinar because we can get experts from all over the country. And I'm very happy to say that I managed to get the relevant experts in the field. So Dr. Renuka Jayat is the pioneer in clinical nutrition in Sri Lanka and also the president of SLMNA. So I'm very thankful for her for giving this talk. And then Professor Pujyati Wickramasinghe is the expert in childhood obesity in Sri Lanka without any doubt. And also the last speaker, Dr. Anil Jayawardena, is the expert in adult obesity in Sri Lanka, as you very well saw from his presentation. So therefore, my task has been made very easy, so I can go through this next presentation very quickly. So we will talk about the dietary management of type 2 diabetes. So first of all, I will look at some of the current recommendations, and then we'll touch on this new concept called remission of diabetes, and then some ideas about dietary advice in the Sri Lankan setting. And then finally, I will touch about some myths about the diet in diabetes, which, although we have been giving these advices and this health education to the public and doctors for a long time, still we see these myths are very prevalent. Now, 1 in 10 adults have diabetes. So 1 out of 10 patients you will see, will most probably at least have diabetes, probably more patients. So therefore, I think if you can take 1 or 2 minutes and give these type of advices, I think we can definitely improve their management. Now, as Dr. Anil Jayawardena said, now initially the dietary guidelines, not only for obesity, but for diabetes was also based on macronutrient composition. So for example, we advised people to go on low-fat diets and so on. But now the current trend is to sort of move into dietary patterns. So for example, there's a lot of data for this Mediterranean diet, and then things like DASH diet and so on. And then so what is important, as Ranil said, is to sort of identify the dietary patterns which are relevant for these different cultural backgrounds and countries, and adapt those dietary patterns rather than strictly going into one sort of diet. So now here you can see the Mediterranean diet, there are a lot of evidence, and here you can see compared to these conventional low-fat diets, the Mediterranean diet was really able to lower the HbA1c as well as the weight over time. So as Dr. Anil Jayawardena said, there is the evidence for the plate method also in the Sri Lankan setting from the studies he has done. Then okay, hold on. Right. So then another important part of diabetes management is weight loss in overweight or obese individuals. And the best evidence so far we have is from the Look Ahead trial, which was a 10-year trial. And there it was clearly shown that compared to the standard dietary support, or rather the diabetic support and education, the intervention group, which underwent intensive lifestyle modification, lost a significant amount of weight as well as their HbA1c significantly improved. Now, in the next few minutes, I will talk about this paradigm shift we have had recently. Now, traditionally, type 2 diabetes was considered to be an incurable condition. So if somebody was diagnosed with type 2 diabetes, that invariably meant that they were accept to having a lifelong disease, and invariably sequentially addition of therapies and sometimes even ending up with insulin therapy was necessary. But now we have this, in the last couple of years, we have this concept called remission of diabetes. So remission means transitioning from meeting diabetes criteria to pre-diabetes or non-diabetic level of glycemia. So for example, the patient will go into a fasting blood glucose level less than 126 or HbA1c less than 6.5 with no anti-hyperglycemic medication. So these people will not be on any diabetic drugs, and their blood sugar will be controlled. So this is called remission. Now remember, the remission is not cure. This is remission. So you have to sort of follow these patients in the future as well. Now the best evidence we have for this diabetes remission came from this direct trial, which was published a couple of years ago, and they had the 2-year data also. So they showed that in overweight and obese or overweight or obese diabetic patients, if they lose about 10 kilos, so that came to about 10 to 15% of their weight, at the end of 1 year, as you can see from this particular graph, close to half of the patients went into remission. So this was astounding results. And even you can see at the end of 2 years, still 35% maintained remission. So this study clearly showed that if you are overweight or obese, and again remember, this was only done in patients with in diabetic patients who had diabetes for less than 6 years. So this is important. This is mainly successful in newly diagnosed diabetic patients. So the take-home message is, if you have a newly diagnosed diabetic patient, nowadays it is a good idea. In addition to controlling the diabetes, you can actually go for diabetic remission with a significant amount of weight loss. So now in the next part, I will sort of tell you how to advise your diabetic patient about the diet in 1 minute or even less. Now when you look at this plate, the first thing that will come into mind is, now probably Ranil and I had a discussion beforehand, and then we had this slide. But believe me, we never even talked about any of these slides. So this shows you that in clinical nutrition, we talk the same language. Now, in the past, we have seen several conflicting messages, in various lectures, TV, media, everything, so that people have got confused about dietary advice. But now I am very happy to see, as you saw in Ranil's lecture, now in clinical nutrition, we actually speak the same language. So in diabetes, one of the most important thing is managing the amount of carbohydrates you consume. So as Ranil correctly pointed out using his research evidence, Sri Lankans consume too much carbohydrates. So the first step you have to talk to the diabetic patient is about their main meal and what their plate should look like. So as he mentioned, only quarter should be the carbohydrate. So here you have the rice, and then half should be non-starchy vegetables, and the other, it should be the protein. So that is the first thing. So you have to follow the healthy plate. Second one, now remember, now we are fond of eating fruits as a dessert. But the thing is, fruits also have carbohydrates. So if you eat a fruit with your main meal, the total glycemic load is very high. So therefore, the blood sugar can go up. So here what we advise is, don't eat fruits with the main meal. I think Ranil also mentioned this for obesity management as well. So instead, eat fruits at least 2 hours after the breakfast, lunch, or dinner. So here there are 2 advantages. First one is, we are reducing the glycemic load because we are spreading out the calories. Second one is, if you have a fruit for the snack, you are replacing an unhealthy snack, something like a short wheat or a biscuit or something, with a healthy option, which is the fruit. So remember, so the first step is the healthy plate. Second step, you tell them don't eat fruits with the main meal. Instead of that, eat fruits 2 hours or more after the meal as a snack. Then, of course, as a third step, you can just take a little bit of time to advise them the things to avoid. Now, we of course know about all these things. So very high calorie items like deep fried food, then sweets, things like biscuits, cake, pudding, ice cream, chocolate, better to limit them. And also sugar, jaggery, honey, and treacle. Now, now people with diabetes know that they have to reduce sugar, but some people say, I don't eat sugar, but I consume jaggery. It's the same thing. So we always have to say all these things basically mean the same thing. And the worst thing of all is the sugary drinks. So the diabetic patient has to limit these things. The fourth step is, of course, whenever we are talking about the diet, we have to talk about the physical activity also. So physical activity is very important in managing type 2 diabetes. So we advise patients to be physically active as well as limit sedentary behaviors like seated time. The target is to achieve 30 minutes of moderate intensity exercises such as brisk walking 5 days a week. This need not be done at a stretch. It can be done in 10-minute bouts. But of course, you have to remember that if this is a person who has been very sedentary, you have to tell them to start very slowly. So maybe do 5 minutes at the beginning, then increase it to 10 and so on. And also you have to specially screen the people for diabetic complications, because depending on the complications, very rarely we might not advise them to go on for exercise. But overall, physical activity is the next most important thing. And finally, weight management is essential. So as Ranil said, and also in the endocrine guidelines also, we have these cutoffs. For Sri Lankans, we consider a BMI of 23 as a cutoff for overweight. So if a diabetic patient has a BMI of more than 23, weight loss of 10% should be aimed at to be achieved in 3 to 6 months. And then maintaining the weight is actually the most challenging one and also the most essential one after that. So again, just to recapture the 5 steps. First one is the plate method. Second one, don't eat the fruit with the main meal. Have it for a snack. Third one, things to limit. Fourth one, exercise. And fifth thing, if you're overweight or obese, you have to lose weight. So very simple. I think you should be able to educate all your diabetic patients about the diet in these 5 steps in less than 1 minute. Now, final couple of minutes, I will talk about some of these myths we see. What is the first myth? Now, people are under the impression that I can control diabetes with medication. Now, I'm taking my medication, so I can eat whatever I want. I'm sure you have heard of these things. So what is the fact? Healthy eating is a key component of diabetic management. So you have to follow a healthy eating pattern and engage in physical activity. At the same time, you have to take your medications also on time. So just because you are following a healthy eating pattern doesn't mean you can stop the medication. So all these are important, but of course later on with the discussion with your physician, you might be able to reduce or altogether get rid of the medications. Right, so let's see. Okay, so the next myth is that eating certain foods will improve blood sugar. So in Sri Lankans, we are very fond of asking, what are the things good for diabetes? What foods are good? Well, there is no single food which is good for diabetes. So no single food will improve blood glucose level. You have to follow the healthy eating pattern. Another myth, red rice is good for you. Some people say when you talk about rice, the first thing they say is, okay, now I am eating red rice. Well, red rice is also a grain. As Dr. Anil showed, if you are eating red rice, again, you have to follow the plate method and the mixed meal concept. It's mainly the most important thing is the quantity of rice. Second one is the type of rice. Kurakka, another important one, you know, I'm sure you have met a lot of patients. People think that Kurakkang is good for you. So people drink Kurakkang Kanda, Kurakkang Thalapa and so on. Well, what is the fact? Kurakkang is a grain. So you have to follow the recommendation for grain. So you follow the plate method. So if you want to consume a Kurakkang roti or whatever, it has to be quarter of the plate and it has to be accompanied with vegetables and the protein. Another myth, it's good to eat a light dinner like string hoppers. Some people say, I don't eat rice for dinner, I just have a light dinner. What is this light dinner? It's string hoppers. But when you ask how many string hoppers you eat, 10, 15 or sometimes 20. Well, again, it's again a grain. You have to follow the healthy plate, mixed model concept, have the vegetables and the protein with a limited amount of string hoppers. And finally, some people are scared to eat fruits because fruits contain sugar. So people don't, so some people with diabetes don't eat fruits. And also, or some people say you have to consume only unripe ones. So you have to have these very mild ripe ones and so on, but that is not necessary. So fruits are a separate food group and they are essential for a healthy diet. Try to have at least 2 fruits a day. However, don't have it in the main meal, have the fruit as snacks, and then also you have to consider portion control also. Just because bananas are good, don't have 4 or 5 bananas. You can have 1 or maximum 2 small bananas at a time. So in summary, an individualized program of medical nutrition therapy should be offered to all patients with type 2 diabetes. Dietary patterns and weight management are important aspects, and remission of diabetes should be aimed at newly diagnosed patients. Thank you very much.
Okay, Sudhir, thank you very much for your very interesting lecture, factory lecture. There's one question we have received directed to Professor Sudhir about, he's asking about coconut. Can give some information related to the coconut. I said some answers are given in previous lectures
Yes.
as well.
Yes. So now one medium coconut has about 1,500 calories. So, so it is a major source of calories in our diet. So now, as Dr. Anil pointed out, if you are following the plate method, you are having half of your plate as vegetables and another quarter as proteins. So if you prepare this with a very rich amount of coconut, then it is not going to help you to lose weight. So therefore, it is very important as Ranil. Now, of course, my diets are much more stricter than Ranil's. So from here after, people will like Ranil more than me. So I always say no coconut. So when you are preparing the vegetables, you have to either have it steamed, boiled, prepared with spices, what you call mirisetta, or stir fried with a little bit of oil. That's how I advise. But of course, as Ranil said, you can have a little bit of what is called the diyakiri or the second milk or whatever. So reduce the amount of coconut because coconut has a high amount of calories. Now, let's say a family of 4 has 1 coconut per day. Each one is getting about 400 calories from coconut. So if you altogether eliminate coconut, you are going to lose 400 grams per week. So that is that easy. That is about coconut.
Okay. Now we came to the final stage of the today webinar on clinical nutrition. I think that my pleasure to and privilege to thanks to all the speakers. And this webinar I had told at the beginning, organized by the Kandy Society of Medicine, jointly with the Sri Lanka Medical Nutrition Association. Now, all 4 experts in the country addressed today's webinar and the different aspects of clinical nutrition. And I hope that I think we touch upon the every main important areas of what we need to know about the nutrition. And the most important thing is, as we call at the beginning to the end, and now we need to follow the standard guideline what we have related to the nutrition. Now, actually, I must thank on behalf of the 2 associations, all 4 speakers, and they gave us the updated knowledge, and they are the expert in our country, updated knowledge with evidence, and that will be definitely supported to all of us, clinicians and everyone, as I told at the beginning, to improve their practices. And I request and invite every doctor to keep your mind and keep your time and think about the nutrition when you are managing the medical or surgical patient or your general practice or your OPD. Are you working on a specialized unit, medical or surgical? This important aspect needs to be addressed because in our practice, as Dr. Jayatisa told at the beginning, nutrition is not part of the management. That should be the part of the management, not without just ordering the diet. We have to individualize the nutritional management, and we need to prescribe the nutrition with the support of our expert, and that will definitely going to improve the patient management. And once again, I'm thanking all the speakers. They are here, and And all our participants, we had a maximum participation. They were up to the last minute, they were staying with us. And I must thank our general sponsorship for the Nestle Health Science. They gave us all the support, including technical and otherwise, to successful program and to webinar. And finally, I'm thanking everyone. Professor Sudhira Kalpana, he actually helped me to organize this, and the members of the faculty as well as the Sri Lanka Medical University Association, all who are supported, thanking again. And we will conclude this webinar, and hopefully we are going to do another webinar on similar pattern in future, and will be informed to all of you. Thank you very much, all of us, all of you, and all the participants who were with us throughout these 2 hours. And we have taken 30 minutes more than what is necessary, but hopefully this will definitely going to improve your knowledge on nutritional status of your patient and your day-to-day practice and your general health as well. Thank you very much, everyone.
Thank you.